Hi, I'm John Mascarenhas from the Icahn School of Medicine at Mount Sinai, and today I'll be presenting myelofibrosis, a year in review. So I'm going to first start with what I think is the most advanced in clinical testing and relevant to the community. And this is a theme of combination therapies, JAK inhibitor-based combination therapies, particularly in the upfront setting. And this has led Manifest-2 study, which I'm showing you updated results here at week 48. And Manifest-2 is a randomized phase 3 study in JAK inhibitor-naive patients combining ruxolitinib plus Pelabresib, the oral pan-BET inhibitor, versus ruxolitinib plus placebo. And Pelabresib is orally administered, 2 weeks on, 1 week off. A lot of preclinical rationale why synergizing these two drugs is more effective for trying to modulate the malignant clone. And then the phase 2 data was very favorable in terms of both spleen and symptom response, and other disease markers of modification. So we saw the week 24 data previously, now published in Nature Medicine last month, demonstrating superiority of spleen and nominal improvement in symptom burden. But what we are committed to doing is following the patients out longer term. And this is the week 48 data. I remain very enthusiastic and excited by the fact that you still have superior spleen response, so SVR 35% at week 48, 57% versus 37.5% with placebo. And then if you look on the right, you can see the durability of that spleen response remains superior in blue with the combination versus ruxolitinib alone. And then below on the table, if you look at that closely, you can see that if you look at any time, because there's nothing really specific about week 24 or week 48, you have a higher frequency, 82% meeting that SVR 35% versus 60% or 57%. And then interestingly and importantly, you have less frequent loss of response, no matter how you define it, with the combination versus single agent ruxolitinib. So clearly deep spleen responses and more durable loss of spleen response with the combination. You also see improvement in symptom burden. So there's a nominal improvement of about 2 points on the total symptom score when looking at the absolute change in symptom score at week 24 and week 48. So it's durable. The graph on the right makes an important point that might be missed by the casual observer, which is you can't really improve the symptoms better than a non-myelofibrosis control population. So the issue here is ruxolitinib is quite good at improving symptoms, and although you get a nominal improvement by adding Pelabresib, it's very hard to show a very statistically significant difference. So very dramatic spleen improvement, but also nominal symptom improvement. And just to end with that abstract, we'll continue to follow these patients out. The durability of the spleen and symptom improvement, progression-free survival. I will say I didn't show it here for sake of time. With Pelabresib, the AE profile actually was very tolerable, and although there was an initial significant concern regarding blast transformation early on, as we follow the patients, we don't see that phenomena increase. So it's not quite clear to me whether there's truly a concern about BET inhibitor-induced leukemic transformation here, which was a very small number of patients that was imbalanced. We continue to follow these patients out, and I think the community at large is very interested to understand whether this combination approach will be beneficial up front. On the same vein of BET inhibitors as a group, these are active agents. The next few slides I'm going to talk about an oral potent pan-BET inhibitor in a phase 1 study presented by Dr. Watts and colleagues at ASH. And here's the schema. Basically, patients who have been on ruxolitinib and were deemed by their physician to be relapse refractory to their prior JAK inhibitor, which is basically ruxolitinib. And then they were given this novel BET inhibitor starting at 4 milligrams once daily. And there's two cohorts. The first cohort was the monotherapy. You failed Rux, and then you got the single agent drug. In the second cohort, it was the patients who had a suboptimal response. So they still had spleen or symptom that wasn't well controlled, and you could add on the oral pan-BET to their stable dose of ruxolitinib. And although this is an early study, I wanted to show this because I think it proves the point that as a class of agents, BET inhibitors are active here. And this is some of the monotherapy data showing the spleen volume response. You can see the columns going down demonstrate reduction in spleen volume. So even as a single agent without a combination of a JAK inhibitor, you're getting reductions of 55%, 48%, 40%. So pretty significant reductions in spleen volume response at week 24. And then if you look at symptom improvement, clear improvement in symptomatology. And this makes sense. Same thing with Pelabresib. You downregulate NF-kappa B, which is potently upregulated in these inflammatory diseases, and patients will feel better because you get significant reduction in inflammatory cytokine expression. So significant spleen responses, significant symptom responses in this early phase dose escalation at different doses, these color-coded. And then if you look at what happens when you add it on, and this is an attractive approach because I think monotherapy gives you a sense of what the drug does alone. Combination therapy tells you probably how can be best utilized in the clinical setting. And here you can see it nicely salvages patients with ongoing residual splenomegaly on ruxolitinib. And the columns going down demonstrate the extent in which that spleen volume is reduced. So to go back to combination therapy, I gave you a taste of advanced testing with Pelabresib, follow-up for safety and overall survival and durability of response, a little early data for a new BET inhibitor on the block. And now let's go to Selinexor. Selinexor is an XPO1 inhibitor. I think the audience is probably familiar with this drug in the context of B-cell malignancies. By inhibiting XPO1, it reshuffles the distribution of proteins and messenger RNAs and essentially targets two pathways that are relevant to multiple diseases, but namely myelofibrosis. Upregulation of p53 pathway, sending cells to either cell death or cell senescence, and then downregulation of NF-kappa B, which again, BET inhibitors also do, so downregulation of inflammatory cytokine signaling. And this is an abstract that was presented by our Chinese colleagues looking at the combination of selinexor at a lower dose than is used in myeloma, once weekly scheduling, to patients who are on ruxolitinib with a suboptimal response. So that's another common theme is, do you add Rux up front, the drug X up front to Rux and JAK inhibitor naive, or suboptimal responders? This is a suboptimal responder evaluation of selinexor plus ruxolitinib, and they're dosing either 40 or 60 milligrams once weekly of selinexor, which of course is orally administered with GI prophylaxis. And again, 25 patients, so not 100 something patients, but a good data set demonstrating, again, reduction in spleen responses, as you can see here. Spleen length by palpation or spleen length by imaging were used, as well as reduction in symptoms by the total symptom score, patient-reported outcome. So selinexor, which may have a history of having tolerability issues in myeloma, when added to ruxolitinib, with some antiemetics, in fact, does have significant spleen reduction potential and symptom improvement as well. And this is from the Chinese data set. This complements and leads to the Sentry study, which I'm showing you here. And this builds off the data of selinexor plus ruxolitinib in the JAK inhibitor naive patient population. Again, there's two themes here. Do we add the drugs up front or do we add them as a salvage therapy? This is going back to like the Manifest-2 approach. Take JAK inhibitor naive patients, and they are randomizing. This is an ongoing phase 3 global study to selinexor 60 milligrams once weekly plus ruxolitinib at the appropriate dose based on platelet count versus ruxolitinib plus placebo. So everyone gets ruxolitinib, but like Manifest-2, is the combination more potent in SVR35 at week 24? And do we see better reduction in total symptom score by the absolute reduction in mean value from baseline to week 24? And of course, we stratify for the usual variables that can affect outcome. And this is a highly anticipated study that will hopefully complete accrual by the summer of 2025. And then ideally by 2026, we'll have some results of this, and we'll be able to compare it to Manifest-2 that I showed you before. How does it look in terms of the extent of spleen response, symptom improvement, and then most importantly to patients and physicians, are these responses durable? Do they warrant combination therapy with additional potential toxicity and additional potential financial toxicity? So I'm going to continue on this theme, I think you can appreciate, with Imetelstat. Imetelstat, which is now approved in transfusion-dependent early forms of myelodysplastic syndrome with an endpoint of improving anemia, has also been evaluated in myelofibrosis. The randomized phase 2 study determined what looks like a survival benefit in the relapse refractory setting with imetelstat at 9.4 milligrams per kilogram intravenously administered every 3 weeks. So that study is ongoing. I think that's one of the more important studies that we have because it focuses on survival in the relapse refractory setting, where the median survival is somewhere around 12 to 14 months after failing ruxolitinib. And in the phase 2, we were able to see survivals that were approaching 30 months. So we'll see in this randomized phase 3 study whether single agent imetelstat further improves survival compared to best available therapy. But this abstract that I'm showing you is more along the theme that I've been presenting, which is add-on strategy. So as that phase 3 is reading out, we're looking to see, can we add imetelstat to patients who are receiving ruxolitinib who have an inadequate response? Again, same theme as was shown by the Chinese Selinexor study. And this stems from preclinical data published by the Ron Hoffman lab here at Sinai, demonstrating synergy, particularly if it's sequenced against specifically CD34 MF cells with imetelstat and ruxolitinib. So this is the Improve MF study, phase 1b study. I like to get right to the bottom line. No DLT. So we dosed all the way up to the highest dose that we were going to evaluate in combination with a stable dose of Rux, and we did not see a dose-limiting toxicity. Most of these toxicities you see listed here are grade 1, 2, and were not really a reason for discontinuation. Even the pain in extremities at 41% was sort of an odd one. I really don't know what to make of that. We didn't really see this in the single agent setting in the phase 2, and I'm not sure if this is a real drug-related issue, but an interesting observation. If you look on the right, there is some cytopenias that are associated with imetelstat. It can be myelosuppressive, but really interestingly, I think the audience can appreciate that you don't see thrombocytopenia on that list. So we didn't actually see grade 3, 4 treatment emergent thrombocytopenia. Why do I stress that point? That's usually the dose-limiting toxicity for most therapies that we give in myelofibrosis. So here we're seeing an add-on approach with imetelstat with the absence of significant thrombocytopenia. And of course, the cytopenias that we do see with imetelstat are not permanent cytopenias. They're reversible, and that's why the drug in this setting is dosed every 4 weeks to give the bone marrow an opportunity to recover some hematopoiesis. So I would stay tuned to see how this rolls out. We're going to show more data at EHA and ASCO. You will notice I'm not showing you the clinical data yet, only because it's too premature to really say anything of substance. We saw some spleen and symptom improvements, but I think the fuller data will give us a better sense of what to expect from an efficacy standpoint, and that is more to come later on in 2025. One last word about cytopenias. I show you these curves to demonstrate that the mean values for hemoglobin, white count, neutrophil count specifically, and platelets remain relatively stable through the core study period, even at the higher doses of 9.4 milligram per kilogram, which is what I'm showing you here. So that has really been, I think, the interest in the combinations space, and as I mentioned, the ongoing randomized phase 3 study called the ImpactMF has yet to read out. This one is really exciting because this is the single agent relapse refractory setting against best available therapy, which does exclude a JAK inhibitor. That's an important point, with a primary endpoint of overall survival. And we don't have a trial yet in myelofibrosis that has been executed, or reported for that matter, with a survival endpoint. It's really been focused on spleen and symptom. And I think the belief here is that this is an anti-clonal, anti-stem cell directed therapy by inhibiting telomerase that could likely affect the disease course and improve survival. So important study, and we're hoping to get a readout of this in the near future. And just so the audience is clear, these are patients who have failed ruxolitinib. These are not the suboptimal responders. These are not the newly diagnosed patients. These are the patients who have documented failure of ruxolitinib, but have platelets greater than 75,000 as a minimum, and have measurable spleen and symptom burden. That would be enrolled in this patient population, and overall survival primary endpoint. Of course, we're going to look at all of the other key secondary endpoints, but overall survival as a primary endpoint in which you can compare across these two randomized arms. So with that, I'm going to bring us to what I think is some of the most exciting single agent data that we've seen in the relapse refractory setting. This is the Boreas study with Navtemadlin, an oral MDM2 inhibitor. So these are drugs that bind a negative regulator of wild type P53. So they activate the P53 pathway. P53 is rarely mutated in chronic phase MF. And by activating P53, you induce cell senescence and apoptosis. And this has been shown very nicely, again, by the Ron Hoffman lab to occur in the CD34 or the MF stem cell pool, thereby leading to a higher likelihood of disease modification, disease course modification. So this study took navtemadlin as a single agent and randomized patients who had failed ruxolitinib to the drug 7 days on, 21 days off, so 28-day cycle versus best available therapy. And what you can see here is that, as we expected with this class of agents, there is GI toxicity, but this is very easy to control GI toxicity in the overwhelming majority of patients. So it's mostly grade 1 and 2. It's mostly early on in the treatment. It can be significantly mitigated with antiemetics. So the similar sort of discussion that we had with Selinexor. And that's probably the biggest differentiator between navtemadlin and BAT when you look across this treatment emergent adverse event profile. Cytopenias can occur, but are often recoverable. And to make that point, I'd like you to see on the right, the platelet count on the top and the mean hemoglobin on the bottom. You get relative preservation of hematopoiesis with navtemadlin as a single agent, 7 days on, 21 days off, in a 28-day cycle in this relapse refractory setting. So very advanced patient population, often with baseline cytopenia. So this is a deliverable drug where you can manage cytopenias and manage GI toxicity. And what we saw here is tripling of spleen volume response. 15% of the patients met the SVR35 at week 24. This is by central review of the scan versus 5% with the BAT arm. And what's important is that there's nothing magical about 35%, but if you look at the extent of response, you can see much deeper and much more frequent responses with navtemadlin versus BAT. Same thing with symptom improvement, doubling of symptom improvement here, TSS 50 of 24% versus 12%. And some of these patients had very significant improvement in their MF-related symptom burden with navtemadlin. And then we had a second abstract, and I tried to consolidate it here for time efficiency, looking at the various aspects of disease modification, including very significant and rapid reduction in circulating MFC34 cells, and correlating that with navtemadlin therapy with spleen volume response, so correlating biomarkers with a clinical outcome measure. And here I'm showing you the reductions in driver mutations as a surrogate for disease burden. So 21% of patients treated with navtemadlin monotherapy had a 50% or greater reduction in their driver mutation, whether it was JAK2, CALR, or MIPL, versus 12% with best available therapy. And you can see some of those responses, molecular responses, were quite deep. And again, these do all seem to track with better spleen response, symptom response, and correlate with reduction in CD34 cell number and reduction in bone marrow fibrosis, which was also significantly more frequent with navtemadlin, in which 47% had at least a grade 1 improvement in their bone marrow fibrosis score at week 24 versus 24%. So again, doubling and tripling here of efficacy endpoints, whether it's clinical or biomarker, with navtemadlin. And with a toxicity profile that can be managed with antiemetics and dose modifications when needed. So this is an important drug. It's very rational. It's clearly active as a single agent in the relapse refractory setting. But where I think a lot of the excitement has now quickly pivoted to is the POIESIS study, which is the abstract that I'm showing you here. And this was a study that was built off of navtemadlin's addition to ruxolitinib in suboptimal responders that was presented previously. And this is now going to be, this is an ongoing study. This is now going to ask a different question than Manifest-2 or Sentry, which is you enroll patients who are JAK inhibitor naive, and then at some latter time point, 18 weeks or so, you reassess the patient from a spleen and symptom perspective. Patients who have a spleen and symptom response are responders they're off the study. Patients who have no response or are primary refractory, they're off the study. It's everyone in between that's a suboptimal responder who hasn't gained sufficient spleen or symptom response are then randomized at that point to the addition of navtemadlin to ruxolitinib, so salvage approach versus placebo, and then looking at the ability to hit that co-primary endpoint at the randomized period of targeted SVR and TSS reduction after 24 weeks. So adding an active agent at a latter time point with the standard of care ruxolitinib in the suboptimal responder. So we're really, I think, seeing a spectrum of approaches to drug development in MF, both upfront and again as an add-on strategy. And this was built off of earlier data demonstrating very significant clinical activity and tolerability, even at low doses of ruxolitinib with navtemadlin in this salvage setting. So I'm going to quickly pivot to something I would say a little bit different than what we were talking about. This is Nuvisertib, or TP3654. This is a selective PIM1 kinase inhibitor that has presented updated results. And I show this because this is monotherapy data. It's a signaling inhibitor that I think is interesting because this group of investigators had done a dose escalation and then had determined that 720 milligrams of the dose of the drug was the active dose of this oral PIM1 kinase inhibitor. And what they saw early on was they didn't see a lot of myelosuppression. If you remember from one of my earlier comments, thrombocytopenia often limits the ability to give a lot of these active agents to patients. It's one of the biggest vulnerabilities that we have with drug development in myelofibrosis, and we didn't really see that with this selective PIM1 kinase inhibitor, whereas previously with pan-PIM kinase inhibitors years gone by, that was the dose-limiting toxicity. It really was not easily administered to patients. So here you can see platelet count of 25,000 or greater was the some of the eligibility criteria that allowed patients to go on. And what the investigator showed was this: with the single agent, you got some pretty significant symptom improvement. And this is 18 patients at the optimal recommended phase 2 dose of 720 milligrams twice daily. So you can see these columns going down, very significant symptom improvements. And then you can see with these icons, you also had patients that had low platelets and low hemoglobins that were garnering these benefits. Why point that out? Just emphasizing the fact that one can deliver this drug even in cytopenic patients and still at the full dose and still get that symptom improvement. And if you look on the right, it was all the different symptoms within the TSS that were really coming down. So it wasn't driven by one specific symptom. It was spleen-related symptoms, cytokine systemic-related symptoms. The whole gamut of symptoms were improved with this selective oral PIM1 kinase inhibitor. And then to reinforce the point, well tolerated from a blood count perspective. So you can see that stability in the hemoglobin on the left and the platelet count on the right, suggesting, in my mind, great drug as a combination partner. As we move drugs forward, either with a JAK inhibitor or maybe as a novel approach. I think things for the MF community to think about as we move these drugs forward. On the theme of thinking beyond sort of disease-focused drugs and signaling pathway inhibitors, I want to spend a few minutes here just talking about a drug called Elritercept. This is an activin ligand trapping activin A and other TGF-beta family ligands like GDF8 and 11. So really affecting multiple aspects of signaling pathways that contribute to the cytopenias that are challenging, as I keep mentioning, in MF. And this drug, which is subcutaneously injected, really, I think, caught some attention because of its early results. So this is a phase 2 study called the Restore study that was administering Elritercept at 0.75 milligrams per kilogram all the way up to 4.5 milligrams per kilogram subcutaneously administered in patients with myelofibrosis that had anemia. So here it was really trying to add on a therapy. So patients can it can be monotherapy or combination on a stable dose of Rux to see, can we improve anemia? A little bit different maybe than the other therapies that are clearly anticlonal or stem cell directed as I've been mentioning here. This is really, can we affect different pathways that mediate the anemia that plagues our patients and complicates their treatment and is associated with a poor outcome. And what we saw, first of all, it was a pretty well tolerated drug. In summary, we didn't see significant concerning treatment emergent adverse events. And even the ones that were characterized are often, part and parcel of the disease rather than likely contributed by the agent. So from a toxicity standpoint, this was a well tolerated agent. And then as monotherapy, as I'm showing you here, we did see improvements in hemoglobin levels, whether it's looking at 1 gram per deciliter increase, nearly 51% of patients versus 1.5 milligrams per kilogram increase in hemoglobin. This is over a 12-week period of time, occurred in 20% and 2 grams in 10%. So seeing improvements in anemia as monotherapy. If you look down below, in combination with ruxolitinib, in which many of our patients, might have spleen and symptom benefit, but continue to have significant anemia or transfusion dependence, we saw 55% of patients had at least a 1 gram per deciliter increase. And you can see some of those increases are quite substantial, even with patients hitting 2 grams and greater in this phase 2 study. So this was an exciting study that's rational, a lot of data on inhibiting TGF-beta superfamily members to remove repression of normal hematopoiesis. So it's a double negative, allowing for better responses. What I'm not showing you here for sake of time was we even saw responses here in improvements in platelet counts, and we have no drugs that do that. So that was an interesting finding. I was not anticipating that. We'll have to understand the biology behind that a little bit better. But also improvement in spleen, which I can't totally explain, but maybe speaks to a broader application of this drug rather than just anemia focus. But clearly anemia has a potential here, and this will continue to develop across MF and MDS and other related diseases. And here I'm just showing you in those patients who were receiving transfusions, both as monotherapy on top and as combination on bottom, significant improvements in reduction in their transfusion burden. So 40% reduction in at least 50% as monotherapy, 24% had transfusion independence, which is quite significant. And then as combination, we saw almost 40% of transfusion independence and 62% had a 50% reduction. So if you were asking me, where is this drug looking the best? I would say in the transfusion dependent population, particularly in those patients who are receiving ruxolitinib, and that's an unmet need. Lastly, totally different than anything I've talked about before, this is cellular therapy. You don't see a lot of cellular therapy in the MF space, at least not yet. This is a phase 1b study from the investigators coming out of mostly MD Anderson, led by Dr. Masarova. And this is with a really interesting unmanipulated T cell regulatory component, allogeneic component that's infused into patients who have a suboptimal response to ruxolitinib with myelofibrosis that have unmet need. Again, you don't really see this in most clinical trial portfolios. But here they were taking cryopreserved, non-HLA matched, CXCR4 enriched T regulatory cells and infusing them into patients with myelofibrosis that were on ruxolitinib with a suboptimal response. And of course, it's for a phase 1 study, sort of limited patients so far. So you're looking at safety first, and then efficacy second. And it looked very safe. We didn't see there wasn't CRS, there wasn't significant infusion related reactions. So from a safety perspective, it looked very safe actually. And then we saw some preliminary data of in some cases very significant spleen responses with these Tregs infused. You can see that patient in green with a spleen of 2,680 cubic centimeters. A normal spleen is 350, so that's quite big, having an over 50% reduction in their spleen volume. So some early data suggesting activity from a spleen perspective, and then on the right, also reductions in symptoms, particularly symptoms related to spleen, so early satiety. So tying in some symptom burden with spleen reduction, and then nicely, and the part that I always appreciate about these studies is the correlatives demonstrating very significant reductions in TGF-beta one level. So TGF-beta1 is massively, as you can see on the right, massively elevated, coming from the MF megakaryocytes and monocytes, and part of the disease, well known to be part of the disease process, is both a fibrogenic cytokine and it negatively regulates normal hematopoiesis. And here with these Treg cell infusions, you were seeing very significant in green in this heat map, very significant reductions in symptom in TGF-beta levels. Again, which look like they might correlate with improvements in spleen and symptom that were observed clinically. So more to come here, but I just want to give you a little bit of flavor of where this field is going and stepping into the cellular therapy arena. So here are my highlights for 2024. Now we're in 2025. I remain super excited about what we're doing here. We're seeing durable responses at week 48 with Pelabresib, the oral pan-BET inhibitor, with ruxolitinib in the JAK inhibitor naive patients. That's the Manifest-2 study. Stay tuned. We're going to continue to follow those patients and provide updates. With the oral potent pan-BET inhibitor 57643, we saw some very early but exciting data, both monotherapy and combination. We'll see where that goes and where they're going to take that drug. Then we saw some additional data from China on Selinexor activity as an add-on salvage approach to patients who are having suboptimal responses to ruxolitinib. And I think this complements really nicely the work that's being done in the Sentry phase 3 study of JAK inhibitor naive patients, combination Selinexor as a rational agent. And then we saw some data with Imetelstat very early on, adding it in the IMPROVE-MF study, adding it to ruxolitinib in suboptimal responders. We'll see some more mature data coming up to see how much clinical activity we're seeing there. But the ImpactMF is the randomized phase 3 study that many of us are looking forward to seeing the results of, with an overall survival endpoint. First time ever. Navtemadlin, I've still remained very bullish about. This is a very active MDM2 inhibitor, activates P53 pathway. We saw some very significant responses, both from a spleen and symptom, with good tolerability in the monotherapy in the relapse refractory setting. And now we're moving into the randomized phase 3 study, the POIESIS study, in the suboptimal responders. Can we convert patients to double responders, spleen and symptom, by adding on navtemadlin to ruxolitinib after about 18 weeks of therapy if they don't have a optimal response? So I think a very important question being asked in the field. And then we see some early data of Nuvisertib, the PIM1 kinase inhibitor, really lacks myelosuppression. We see some pretty significant symptom improvement. I think it would be a great combination partner. And then Elritercept is this activin ligand trap, reducing TGF-beta family member signaling pathways. We saw early on some significant anemia, particularly in combination with ruxolitinib from a transfusion independence perspective, but also improvements in platelet count and symptoms and spleen. And we need to see where this is going to go. So we look forward to updated data here. And then lastly, the CK008 Treg infusions, early data looking like it has some signal of activity, very well tolerated. Need to see some more mature results, and looking forward to that as well. So with that, I'll end, and thanks for inviting me.